it over to Roberta.
Good afternoon, everyone. I'm Roberta Pressman, the co-leader of the Healthier Aging team. Welcome to our health and wellness lecture event on dementia. So happy to see so many of you here today. Before we begin our presentation, however, I have an exciting announcement to make. I want to let you all know that after a very, very long search, we have a new addition to our Ashby Village staff, Karen Dean. She'll be our Member Support Services Coordinator and will be overseeing all of our member support services. Karen actually is just the first of several other newly hired staff who will be meeting very soon. And she'd just like to say a few words of introduction to you before we all begin. Welcome, Karen.
Thank you. Thanks, Roberta. And hi to everyone. I'm excited. This is my second week here at Ashby Village, and I am busy learning all about the village and the really wonderful ways to support folks here in the East Bay. So definitely looking forward to working with you, meeting with you, and collaborating on more presentations like this going forward. But I know there's lots else to say, so I just want to do the official spiel, which is to kind of let everybody know that if you're interested in learning more about becoming a member, a volunteer, a donor, or just an Ashby Village enthusiast, please come and join one of our upcoming neighborhood living room chats. They are virtual, and our next one is going to be held on Tuesday, November 16th at 2 to 3 p.m. And Suyan's going to put information in the chat box. And then finally, this is going to be a wonderful presentation, and these events are free for everyone to attend, but Ashby Village does rely on donations from the community to bring programs like this to our members and friends. So once again, I want to bring your attention to the chat box where Suyan has placed a link for a simple way to make a tax deductible donation at your convenience. And you can also come to our website anytime. And we really thank you for your support and appreciate everyone's attentiveness to this topic. So it's going to be a great discussion. Roberta.
Those of us on the Healthier Aging team are so happy to bring this long-awaited Embracing Change presentation to you by two distinguished researchers from the University of Wisconsin at Madison. As many of us at Ashby Village have aged ourselves or have loved ones and friends suffering from mild to severe types of dementia, there's been a very growing interest among us at Ashby Village in learning more about dementia, what it is, can it be prevented, and how best to treat it. We are so fortunate today to have two people who can help enlighten us about this disorder. Dr. Rebecca Koscik and Dr. Kimberly Mueller. Their research has mainly investigated identifying early signs of dementia before it even appears in observable behavior. Dr. Rebecca Koscik is a senior scientist at the Alzheimer's Institute at the University of Wisconsin School of Medicine and Public Health. She has spent the past 12 to 13 years studying the early signs of cognitive change. She also has been researching how Alzheimer's biomarkers change over time and has been developing methods for identifying the age when amyloid plaques begin forming, even before behavioral changes are noticed. Dr. Kimberly Mueller is an assistant professor of speech and language pathology in the Department of Communication Sciences and Disorders at the University of Wisconsin. Her research focuses on understanding speech and language changes across the spectrum of normal aging and through pre-Alzheimer's, mild cognitive impairment, and other early forms of dementia. Her research has focused on looking for detectable changes in patterns of speech, such as structural changes in sentence formation, before behavioral changes secondary to dementia are detected. Welcome to you both.
All right, okay. Thank you, and I will begin sharing my screen. This one. And does the slide version look okay to you guys?
Yep, looks great.
Good. So let's make sure it's advancing. There we go. Kim and I both want to thank you for the invitation. Thanks for that introduction, Robbie. Very kind. I come in all humbleness. There's tons of people who contributed to what we're presenting today, and the work to understand healthy aging is literally a worldwide adventure that tons of people are working on. So some of the slides we're presenting today are from our colleagues. And of course, what we're sharing wouldn't be possible without all the people who are involved in our research and our community-based efforts. So I'll be talking of, we'll tag team a little bit, and we'll begin with an overview of healthy aging and then move into some of the types of cognitive decline. And then I'm going to talk about biomarkers, because you'll hear that talked about in the news and in science that's being reported, and your doctors might talk to you about it as well. And then we'll spend a little bit of time sharing some results from a big study we work on here in Wisconsin, and then finish with Kim will go over a whole bunch of different treatments that are possible these days. So more good news than bad, I hope, in this presentation. So this is a figure I'll spend a little bit of time on, because we'll come back to it at different times. A lot of times when we're talking about cognitive aging, we have this sort of generic graph where on the y-axis, the high end of the y-axis is the healthiest cognition a person has had in their life. And then as you go lower, it's declining. So we all have different levels of cognitive abilities, but in general, we all peak at some point, and then we have declines. Then on the x-axis, we just have a very generic age axis, because some of us start declining sooner and some later. And in healthy aging, it's a fairly modest drop. And our brains are healthy, and we can keep learning new things, and we have good neuroplasticity. Now, if we're unlucky, or as you know, what is happening in our bodies also results in accumulating brain changes, then we might end up with a cognitive trajectory that's on this red line. And as you our cognition changes incrementally year by year, but there are spots along the way that get diagnostic labels. So we'll talk a little bit today about this category of mild cognitive impairment. And then as declines worsen, there's another category that we all know called dementia. So we'll talk a little bit about each of those. And dementia is actually not a part of healthy aging. It's occurring because there are brain changes happening under the surface. And we'll talk about some of those brain changes today too. So what are the types and causes of cognitive decline? Let's start with mild cognitive impairment. Mild cognitive impairment is a category that was developed a number of years ago, maybe 15 or 20 years ago, when people recognized that signs of dementia were occurring long before dementia diagnoses were made. So people tried to operationalize how you can identify this early. And it includes a significant change in memory or other kinds of thinking skills from where you started out. People with mild cognitive impairment can actually still do their regular activities of daily living, and they can live independently, but their cognition is changing. And there's concern noted by themselves or someone else, a family member or a good friend. And what we know about mild cognitive impairment is that if you have it, you're at increased risk of developing dementia within 5 to 10 years after that. But it's not always a done deal. Lots of people with mild cognitive impairment can resolve some of the cognitive issues. So it's important to pause then and talk about what are some sources of or contributors to mild cognitive impairment. And if I say MCI, that's also what I'm referring to. Well, we know that untreated depression, stress, and anxiety can have an impact on how we're thinking. We also know things like thyroid problems, kidney problems, other bodily systems that are out of whack can lead to confusion and impact our thinking. Sleep apnea or other sleep disorders are significant contributors at times to either worsening memory or worsening executive function, kind of like how we're doing our daily tasks. It might relate to driving reaction time, for example, and things like that. And then other conditions that affect blood flow to the brain, like a stroke or a traumatic brain injury or other things, those can also contribute to symptoms of mild cognitive impairment. Other things too, like vitamin B12 levels or other nutrients can contribute. So this list, and there's a few more on the next slide, but I just want to pause and say, sometimes people are reluctant to go and talk to their doctor about their cognitive symptoms because there can be stigma attached, but it's important to have those conversations because then all the underlying potential causes can be examined and considered. And if there are things that can be done to help be more healthy, it'll help our cognition. So other possible causes are infections like urinary tract infections or other, COVID has caused quite a bit of confusion for folks. Those sorts of things can contribute to mild cognitive impairment symptoms. And then there are also potential side effects from prescription medications, as well as there can be medication interactions. So if you notice confusion after changing your medications, you might want to talk to your physician or your pharmacist. Other contributors are a history of alcoholism or ongoing excessive substance use. And one thing we also know is that vision problems or hearing problems can contribute to doing poorly on cognitive tests or to being less engaged with things that are cognitively stimulating, including social interactions. So addressing our hearing and vision problems is really important to look at. And then last but not least, we can also have underlying brain changes like atrophy or formation of different pathologies like protein that contribute to mild cognitive impairment. So that was that early part of the curve. Then if a person's cognition continues to decline, eventually they'll reach a dementia diagnosis. So now we'll talk a little bit specifically about what Alzheimer's disease is, and then more generally about Alzheimer's or dementia, because people often think they might be the same thing. Alzheimer's disease specifically, it's a neurological disorder, and its memory loss is probably the hallmark symptom, but other cognitive decline can happen. There's specific types of pathology changes we'll talk about more in a couple of minutes associated with Alzheimer's disease. But the cognitive symptoms start slowly in most people and advance relatively slowly. And we diagnose it by looking at cognitive assessments, and then also looking at biomarkers. So these are some examples of tests that people might end up taking to help understand, is this Alzheimer's or is this dementia? And so you would be asked, if you went in for testing, to do different activities that help us understand what's going on inside the brain. But Alzheimer's disease is just one of many causes of cognitive impairment. And it's Alzheimer's disease dementia is just one of several types of dementia. So in dementia, you can have memory problems, you can have problems with planning and organizing, speaking, making decisions, all sorts of things we take for granted in day-to-day life and our thinking can get a little haywire with dementia. And one of the biggest pieces, it's called dementia when those problems result in impaired functioning in daily life. If a person can't drive anymore or balance their checkbook or follow recipes or do different things, those are things that are starting to impair your functioning. Now, there are many, many different types, and you've probably heard of several of these. And this pie chart, the biggest slice of the pie is Alzheimer's. That is the leading cause of dementia. Then there are other ones, like there can be dementia associated with Parkinson's disease, frontotemporal dementia, Lewy body. My dad had that, and that's a tough disease. to see. There's vascular dementia, and then mixed causes. Very few of us age in just, have one thing happening in our brain. So the mixed cause dementia is also a very big slice of the pie. And why are there so many different types, and how is understanding what type it is important? Well, this shot, we aren't going to go into lots of details, but I like the overview picture because it helps us see that these different parts of our brain are related to different aspects of our functioning. And some pathologies, some of the dementia types land more in some parts of the brain than others. Like Alzheimer's tends to be more in the temporal lobe, and some in the parietal and occipital, but other dementias tend, the frontotemporal lobe is not surprisingly in the frontal lobe, and so on. So if we understand what's happening in the brain, we have a better understanding of what the thinking problems are and potential treatments. So now let's go specifically into Alzheimer's. What is happening in Alzheimer's disease? And I'll just say a little bit now about the nomenclature. In our research groups, we differentiate between Alzheimer's disease and Alzheimer's disease dementia, because dementia is the cognitive manifestation of Alzheimer's disease. But Alzheimer's disease actually refers to when amyloid plaques appear in the brain, when tau tangles form, and then when other things like neurodegeneration start occurring. So if we know somebody has amyloid plaques, they are said to have amyloid pathology. If we know they have amyloid plaques and tangles, we say they have Alzheimer's disease. So it's Alzheimer's pathology, Alzheimer's disease, and then when the cognitive symptoms occur with functional impairment, it's Alzheimer's dementia. So back to this graph again that we saw in the beginning, when somebody's on that trajectory and we know they're headed towards dementia, we can use biomarkers. In the past, we could only know exactly what the cause of the cognitive problems were using autopsy, especially for Alzheimer's. Somebody could have a diagnosis with Alzheimer's, but you didn't know until you saw the brain if there were plaques or tangles in the brain. Now we have biomarkers that we can look at. So what is a biomarker? A biomarker it's a kind of a fancy word for just saying anything that measures what's happening in our body. And they get used all the time for different things to help diagnose diseases, identify health conditions, to monitor if we're responding to treatments, or to check for changes and things like that. For example, we've all had a biomarker probably drawn when we had our cholesterol examined. That is a biomarker for heart attack risk. Dementia biomarkers, on the other hand, are ones that specifically help us kind of peer inside the brain without actually going inside the brain. So we now have ways of measuring whether there's amyloid pathology or tau pathology, all these things, inflammation, iron toxicity, synaptic dysfunction. The technologies are extraordinary that have evolved over the last 10 to 20 years. And there are a variety of sources of information on these biomarkers. For example, and the one that's in boldface we'll talk more about in a little bit, we can understand what's going on in the brain by using brain imaging. PET scanning, positron emission tomography, is a mouthful, so we'll just call it PET scanning after this. There are some amazing dyes these days that can be used that will bind to amyloid protein or to tau tangles. This was not available 20 years ago. So it's pretty cool that it's evolving now. MRI scans can tell us about blood flow. They can tell about white matter and gray matter and whether or not parts of the brain are shrinking relative to others. CT scans can give similar information. Other biomarkers include samples, like fluid samples, we'd say in our lab, talking about spinal fluid. spinal fluid actually gives really good information related to amyloid and tau. But they're also developing biomarkers using blood. So I would say probably in the next 5 years or so, if not sooner, we will have reliable ways of measuring amyloid and tau in blood, which would change the game in terms of understanding early signs of disease. People are also looking at saliva for biomarkers, or even stool, and looking at the human microbiome to look at how that is related to our brain health. So there's a ton of fascinating biomarker work in those areas. And then probably the newest cutting edge, and Kim does work involved in this area, is digital biomarkers, where you can have wearable devices like we all know our smartphones are collecting data on us all the time, whether we want them to or not. But people are leveraging all these things that we have around us to collect more digital biomarkers, and they can tell about our gait, they can tell about our speech patterns, they can sort of detect early subtle signs of decline. And we're just, with some of the machine learning techniques that are out there, we can leverage all this really rich data. And so the next 5 to 10 years are going to see extraordinary developments there as well. Most of these things are used in research these days because they're quite expensive, and without an effective treatment for amyloid, there hasn't been a medical reason to get it. But we'll get there later. We'll talk about aducanumab a little bit later. All right, so now to dive a little bit deeper into just this one biomarker source of PET scans, and to give you a little sphere of reference for how new it is, the graphs at the left here, the measurement of amyloid plaques was developed in the early 2000s, I believe, and then we started using it here in Madison in 2006. So this graph, I think can you guys see my arrow moving? Okay, good. This graph would be, this picture is from a slice of tissue you would have gotten at autopsy. That used to be the only way you could tell if amyloid plaques were present. Now with the PET PIB scans or other, PIB is one of the dyes. There are lots of fancy names for it. PIB stands for Pittsburgh Compound B, so we call it PIB, but there are other dyes. But the important thing is what they allow us to do is it lights up parts of the brain that have amyloid. So you can see this one on the left, the yellows, oranges, and reds are, the red is the most intense, kind of like our radar trackers. The color trackers are the same thing in our brain, with red being most intense amount of amyloid. Then the blue and purple in the control brain, this is a person with a healthy aging person. So you can see that visual tells you, yes, that you can really see the amyloid in the brain. Now, just recently, way more recently, in 2017, the FDA approved this tau tracer, MK6240. So now we can not only look at plaques via PET, we can also measure tau. And again, it's very similar. This picture is of what you would have seen on autopsy. And then this picture at the right is what the PET scans look like. And on the top, you see a person who doesn't have amyloid and doesn't have tau. You see a little bit of stuff lit up here because they call that non-specific binding. So that tracer does bind a little bit, and they know this from the studies. So that is not actually something we worry about. But then this one is a person with Alzheimer's. They have amyloid, and let's see. You can see with the reds, I lost my arrow, there it is. With the reds, there's a lot of tau here and here and here. So now we can have a good understanding of people and what's happening in their brain. Now, how does that fit in the overall path to dementia or to cognitive decline? This picture is one we'll look at. You'll see this a lot if you're looking at any articles about Alzheimer's and the development of symptoms, because this is a hypothetical model that was put forth. This version is from 2013, but I think around 2010 was the first time Cliff Jack and his team at Mayo Clinic put out this hypothetical set of lines. So we'll talk briefly about it. On the left, kind of like in the beginning with the cognitive axes, what we have is min to max, the lowest amount of a specific unwanted thing in our brain to the highest amount. So this is just like from healthy to not so healthy. Then this line talks about the detection threshold, and every assay we have, including for things like cholesterol or other things, there's a detection threshold that you have to be able to measure it. But especially with PET scans and things have to bind. And so when we get a reading, we know it's based on what's bound and detected. But anyway, so the hypothetical framework is we think you can detect changes in amyloid first in spinal fluid, and then in the PET scans. And then after amyloid has been detected, we think tau forms later, and that you'll find that first in the spinal fluid. And then what they need is another line for PET. And then we also know sometime after that, we think you can start seeing the neurodegeneration through MRI. And then sometime after that, we know that we start seeing changes in cognition. But as you can see on this time axis, it's kind of vague. It just says time. Is it years? Is it months? Is it decades? So that's one of the puzzles we're trying to sort out here. And key questions we're trying to answer about it are things like what factors influence if somebody starts developing Alzheimer's pathology. So when does the CSF start changing, and when does it start changing? Other key questions are, do we know when people with the pathology will actually start landing in this green zone of cognitive impairment and changes there? And then what is the timing between these various events? How many years are there between amyloid and tau, or between amyloid and cognitive change? These are all things that we're trying to figure out. And to do that, we need to be able to define this Alzheimer's disease. AD just refers to Alzheimer's disease time axis. Usually we plot things versus age, but if we can shift things to a time axis that represents Alzheimer's disease, we're going to understand the disease better. So that's where we start getting into some of our local research findings. Yeah, at Wisconsin, there's at the medical school here, there's cancer and Alzheimer's research are the two main focuses that they've been designated as the priority focuses. So we have two large sister studies here. We've got the Wisconsin Registry for Alzheimer's Prevention, which I'll talk about today. And then we have an Alzheimer's disease research cohort. And center. And there are centers in California too. I think San Francisco and San Diego both have them. So if you get inspired and want to join in some research, we could probably help you figure out how to get connected with research in California. But what we're doing here in Wisconsin, and most of these big studies are using imaging and spinal fluid and now blood and digital biomarkers and things to try and understand changes in these biomarkers. We're watching lifestyle and health and cognition over time. Now, our study, the Wisconsin Registry for Alzheimer's Prevention, has over 1,600 people in it. We've been following people, the earliest enrollees started in 2001. So some people have been in the study for 20 years now, and that's pretty exciting. And one thing that was unique about the study early on, but there are more cohorts around the world now that have done this. Mark Sager and Bruce Herman, when they started the study, they said, if we want to look at midlife factors and we want to see things happening, we should have more people whose who have a parental history of Alzheimer's in our study, because we know that having a parental history does increase risk. So what if we get more people who are healthy and have a parent with Alzheimer's in our study? We'll see changes sooner. So we have about 70% of our sample that has a parental history of Alzheimer's. And we have people participating from all across the country and almost every county of Wisconsin. The average age at their first visit was 54, with about 11 years of follow-up so far, and anywhere from 0 to 20. We're still enrolling people. And our main goals, we really want to understand, it's widely accepted at this point that by the time you reach Alzheimer's dementia, the amount of brain changes that have happened make it very hard to recover from. There's nothing we know of right now that you can recover from. So we wanted to be able to swim upstream from that far enough so we can start doing things in life before our brains are changing much to prevent those sorts of changes from happening. So we're looking at all of these different variables and trying to understand how everything fits with our cognitive change over time. And what we know, we've measured all these things in our study because we know, I'm not going to read each one of them, but we know that there are a lot of risk factors for Alzheimer's and for other dementias. So the column on the right we'll come back to in a little bit because we do have some lifestyle data we'll share. So now I'll talk just a little bit about some of the pretty fun stuff we've been learning about our PET amyloid data. So we'll spend a little time on this slide because I'm going to use it for a while. I'm going to use the graph on the right for a bit. In a subset of people, we did PET scans. We can't do them on everybody because they're very expensive. So our funding allowed the PI Sterling got another supplemental study called PREDICT, so we could do these PET scans in, we're over 200 people now, but right then we had 170. And what you can do with longitudinal data is you can create something called a spaghetti plot. And a spaghetti plot is a fancy way of saying, I'm gonna let each person who has multiple visits have their own line. So in this figure, you know, this person, this line represents one person's amyloid, and you can see that it went up. And so the measure is called global PIB-DVR. That's our thing that tells us how much amyloid is there. This line tells us the difference between, we say, yep, if they're above 1.2, yep, they definitely have amyloid. And if they're below 1.2, we say it's amyloid negative. So what we can, well, actually, I'm going to pause there and let you just look at it and soak it in. Just thinking about the graph. They say a picture is worth 1,000 words. So what do you glean when you look at it? I'll give you about 5 seconds and then. Okay. So here's what we noticed. And I have to keep moving my little speaker bar around. This group circled down here, what we noticed is, look at that. Most people in our sample are not getting amyloid. That is, the cup is half full part of the story. So 78%, in fact, of our sample who participated in here have not developed amyloid. But what we also noticed, this blue group, this group I circled here especially, some people are getting, this PIB is accumulating at very young ages. Some, as early as 50 are developing amyloid. Another thing we noticed about this graph that's really interesting and actually pretty unusual in biological processes is that that most people just can't, once they start going up, they keep going up. It's monotonic. So when we were looking at all that, it led us to a series of questions that were important for us to try and understand and answer. So still looking at our little spaghetti plot. So one of the things we've been thinking about, you know how in medicine, we love to dichotomize. You either have a high blood pressure or you don't, but that threshold keeps changing. Or you have, we just put things into categories a lot, but it's possible that we're losing information that way. So for example, this person, there was one person at age 65 with an amyloid DVR value of 1.89, and another person down here, they're both called amyloid positive, but are we losing information by just calling them amyloid positive? Because one's value is way higher. And that's kind of like saying if somebody had a blood pressure of 200 and we were comparing that, a systolic pressure of 200, is that they're both 200 and 145 are both considered high blood pressure, but is there a different impact on the brain from the two? So we wanted to dig into that further. Then as we thought about this crossing of the line at different ages, like, well, does how long the amyloid has been in the brain matter? And so we started asking ourselves the question, what if we could use these longitudinal patterns with age to come up with some sort of amyloid positive age estimate? And for example, I picked out 3 people that cross the line. This one crosses around age 50, this one around age 58, and this one around age 75. So the fact that they're all amyloid positive is an unhappy thing, but perhaps crossing at 75 is much better than crossing at 50. So then the challenge became, can we take this and convert it to a different scale from age, to an actual amyloid time scale? And so we used a process called group-based trajectory modeling, and figured out there were these different functions that described our subgroups, and we could use those to get a weighted estimate for each person. Each person, we could estimate their age of amyloid positive if they were in one of these groups, the early accumulation, middle, or late. And so then, this is the drum roll, the scientist drum roll, we wanted to say, can we make it, if we align those values, the global PIB-DVR values, by that new time scale, is it going to look like that hypothetical curve we talked about earlier? And here's what we saw. When we aligned by this PIB chronicity, we did indeed see that there is a fairly consistent, predictable pattern of accumulation in amyloid that takes a number of years to go from just starting to passing the threshold, and then it continues climbing for years after that. And it was a pretty happy day in Scienceville in our unit when we figured out that we could do that. So how is that useful then? Well, once we knew how long amyloid had been in somebody's brain, then we could use that to understand our cognitive data. So this is just a picture. The PAC-3 is a global cognitive score. And you can see we did an interaction. And so basically what that was we were saying, we know that there is decline, small declines with age, just in general, in healthy aging. But if we factor in as well how long they've had amyloid, or if they didn't have amyloid, do we see different rates of decline? And this basically tells us the black line looks like that black line we had in the beginning graph of healthy aging. These are folks without amyloid in their brain, and their cognition is changing a little bit as they age, but not that much. And then it turns out the longer amyloid has been present, the faster the decline is happening. The other thing the amyloid chronicity scale helped us learn was we could think about the other biomarkers. Everybody's always thought that tau came after amyloid, but it was also related to age. But when we used the chronicity scale, it explained way more of the development of tau than age did. So we were able to show, yep, tau does come, detectable tau does come after detectable amyloid. So that's one of the biomarker things we've been finding, and why it's important for us to be able to measure the dementia biomarkers. And then just a couple more things before I turn it over to Kim. We also look at lifestyle factors. So I have to back up. These next two slides are from an up and coming star, Carly, in our lab. She's a PhD student, and she's been doing some fantastic work looking at modifiable risk scores. And there's another group has developed this Libra index. That's the lifestyle, the brain. I should have written out the acronym. I'll remember it later. But it's like the Framingham risk score or other risk scores you've heard of, but this is specifically around brain health. And so it takes things into account, this list of things: your alcohol consumption, cardiovascular disease, physical activity, your kidney function, diabetes, cholesterol, smoking, obesity, blood pressure, depression, and cognitive activity. And then you get points. Either you get lower risk for not doing something, or you get higher risk for having more of something. And so in our sample, we added some of the measures later in the study. So we had 1,200 people with baseline Libra. The median score was 0.6, and the score ranged from -4 to 8, just so you guys have that as background. But what we ended up seeing, and we looked at how many people who started out cognitively unimpaired does that Libra risk predict cognitive impairment coming on later, where we used sort of a liberal definition. So we included people who were showing early signs of clinical change. And we did see that if you have a higher Libra score, you have more lifestyle risk, then cognitive impairment did show up earlier in our group. And we can come back to that later, but now I get to hand it over to Kim.
Hi, everyone. So I'm Kim Mueller, and I'm very grateful to be here. So thanks so much for having us. And I'm also very grateful to work with Rebecca. As you can see, a lot of that work was really done by her. So really exciting, groundbreaking work that we think is going to really lead to more discoveries about treatment, which is what I'm going to talk about now. And so I'll talk about both pharmacological or drug kind of treatments that are available right now, but I'll also talk about non-pharmacological treatments that have to do with modifying lifestyle or improving quality of life for people living with dementia. We should just remember that over 7 million people in the US are living with dementia right now. And so while we're working so hard to understand what's happening before dementia sets in, there's still this very large population of people who are living with dementia that we need to understand how we can maximize their abilities and help them live a good quality of life for as long as possible. So there are FDA approved treatments for Alzheimer's disease dementia. And what these treatments do is treat the symptoms of dementia, but not the actual disease that Rebecca was talking about. So not the actual pathology of amyloid or tau, but instead they treat the symptoms. And so some of these are cholinesterase inhibitors. So you may have heard of the drug called Aricept. And what those drugs do is kind of increase one of the neurotransmitters called acetylcholine in between the two cells that are communicating. So in that synapse, it increases this neurotransmitter that is involved with memory. And so for some people, that kind of drug actually helps them maintain their abilities for a period of time. Other people don't feel or notice benefits to that kind of drug. And they can have some difficult side effects, such as stomach upset and so forth. So that's one treatment of symptoms. Another one is very similar, called memantine. And so they both try to help maintain memory for as long as possible. So the question here, though, is what if we can not just treat symptoms and actually treat that disease, that pathology in the brain. And that's what you've been hearing about in the news for sure lately, is these drugs that can actually treat the disease process. So as we saw from Rebecca, it's about 20 years from when we see this amyloid positive scan on PET imaging to when we see the cognitive impairment. So we have this important 20-year window of time. And the question there is, will amyloid clearing drugs, so will drugs that actually dissolve those plaques of amyloid, will they change this trajectory that Rebecca showed you a couple of times now? Can we treat this back here and then change how this disease unfolds? So that's leads us to this very newly FDA approved treatment for Alzheimer's dementia, or for Alzheimer's disease, actually, that treats amyloid plaques. And so the name of the drug is aducanumab or Aduhelm. You may have heard these two in the news. And what this does is it sort of sticks to the amyloid plaques and then dissolves them and activates the body's immune system. So the hope then is that by dissolving these amyloid plaques, the neurons will stop dying and the memory and thinking will remain stable. And so what they have done to test this drug is to do those PET scans and find people who have amyloid in the brain and who still have a lot of cognitive function left. And they put the people on these drugs to see if they were safe and tolerable. And then, the main goal, of course, is, are they actually going to help cognition? Are they actually going to prevent cognitive decline? But also, are they going to dissolve the plaques like they said they would? So what the studies have found is that the amyloid plaques definitely disappear, but you may have heard about controversy in the field about this drug being approved by the FDA, where some FDA members actually resigned over this because they didn't agree. And so part of the controversy was that the findings about the cognition improving or being maintained or preventing decline were very inconclusive. So there was a problem with that kind of data. But for sure, the amyloid plaques were dissolving by that drug. So the other problem with the drug is that it's extremely expensive and there are significant side effects that can occur. And so the question is, what's the risk and benefit for particular patients? Many primary care or gerontologists are very excited to have something to offer their patients. And so, it's definitely hopeful, but it's not without its controversy because of that. So there are more drug studies that are going on. Additional different types or classes of amyloid reducing drugs are being investigated. There are also new drugs that are looking at that second part of the pathology, which is the tau tangles. So drugs are being investigated to stop that process. Other medications that reduce inflammation or protect nerve cells. And then there's this non-pharmacological class of treatments that the hope is that by doing these treatments, maybe we'll stop or prevent amyloid from occurring in the first place. One more anti-amyloid drug is I can't say it. Donanemab, thank you, yes, which is another anti-amyloid drug by Eli Lilly. And so we have this on here because if you take a look there, the clinical trials website, clinicaltrials.gov, they still are enrolling people in this drug trial. And so if that's something that you'd be interested in participating in, you can look up that clinical trial and see if there's a site near you if you want to participate in that. This drug has some nice findings so far, so they're continuing on with later phase drug studies for this. Okay, so then I'm going to talk to you, just looking at the time. So we're going to aim to end in about 15 minutes so that we have plenty of time to answer your questions. But I do want to talk about non-medicine treatments for dementia. So strategies that can possibly prevent cognitive decline or slow it down or maintain abilities for as long as possible. So one treatment that has the most promise out of all of the non-pharmacological treatments is physical activity and exercise. And so this has been shown to increase the activity of specialized brain support cells called microglia in the brain. And so there's been a direct correlation between an increase in exercise and increased activity of these protective brain cells. It's also been shown to decrease inflammation in the brain and to improve cognitive function. So it's very promising, and there are a lot of exercise trials going on throughout the US. So that's another possibility if that's something you're interested in participating in. So let's see, this slide is kind of just going over, what are the mechanisms or what are the possibilities for future research in terms of exercise, and what are these underlying mechanisms behind the improvement. And these are some recommendations that kind of say that what we need to do is understand what's actually going on in the brain when we put people on these exercise trials, so that we can further understand the mechanisms behind the improvements that we see and kind of make a case for these kinds of exercise treatments. So another treatment is cognitive activity. So you also may have heard about doing crossword puzzles is good for your brain. But it's not only crossword, there's nothing special about crossword puzzles. And what it is challenging your brain in some new way is what the research is starting to show can be helpful for cognitive function. So that includes crossword puzzles and games, quilting, photography. All of these things have been studied in non-pharmacological clinical trials. Another one is computerized brain games. And I always get a question in talks like this about Lumosity or some of those other brain games that are heavily marketed to older individuals. Those are also nothing special in and of themselves. And the research behind those is showing that you actually do get better on those particular games for sure. But it's been really hard for anyone to show a transfer of that skill. So doing those computer games, you get better at those, but you don't necessarily get better at driving a car, or your reaction time in driving a car, or get better at remembering where you put your keys and those kinds of things. So that's what we mean when we say we're not really seeing transfer of skills in those. However, if it's something you enjoy and it keeps your brain active, we still think there's some benefit to that. But just beware about spending money on things like that, especially if you don't like it. We would rather see you take piano lessons or learn a new language or some other way of challenging your brain that is enjoyable to you, so that you continue to do it. That's the main thing. All right, another promising treatment is diet. And the one type of diet that has the most evidence behind it is the Mediterranean style diet. There's one in particular that's kind of a combination between the Mediterranean diet and this hypertension diet called DASH, which is kind of low sodium for high blood pressure. And this is called a MIND diet. So you can read a lot about the MIND diet. There's a book that you can get at the bookstore about the MIND diet. or just look online to understand the components of that. But there's some really nice findings about maintenance of cognitive skill, or people who tend to eat that way tend to have a slower rate of cognitive decline as they age. So there are randomized controlled trials that are attempted, but they're really hard to do to monitor the participants' diet at all hours of the day. It's really difficult to do trials like that for diet. But there's promising aspects of the MIND diet, not to mention it does improve your overall health in terms of blood pressure and other risk factors that affect your brain by reducing risk of stroke and so forth. So another treatment is social activity. So we, of course, are obligated to show the Green Bay Packers because we're here in Wisconsin. So we thought of it later. Maybe we should have had a California team, but we didn't even know what that was. I'm so sorry. But anyway, we have these Packers here, but having an active social life is associated with a reduced risk of dementia in many observational studies. And in people living with dementia, the social network does actually get smaller because it's harder to be in social situations if you're living with dementia. And it's also, unfortunately, harder for other people to engage with people living with dementia. A lot of people don't know how or feel uncomfortable. So we see this narrowing of the social support. And so what we hope is that by increasing the awareness that by engaging in social activity, you could have better cognitive function is an extremely important piece. So hearing aids, hearing loss is a common co-occurring problem for people living with dementia. If you have hearing loss, you're at an increased risk for developing dementia. And the mechanisms of that are not fully understood. Whether one happens because of the other or first or second is not well understood. But hearing loss is really affecting cognitive function. So if you're having trouble hearing, it can even affect your memory because you're constantly working so hard on hearing that these other cognitive skills can tend to suffer. And so treating hearing loss is extremely promising in terms of maintaining cognitive function, just in the general population, but also in people who are at risk for dementia. So there's a Wisconsin hearing aid study that's hopefully coming soon, where we're going to put people who have MCI on hearing aid treatment and look at their ability, cognitive ability over time. So that's an extremely exciting kind of clinical trial of hearing aids. Other things that are being investigated are spiritual fitness or mindfulness-based stress reduction, meditation effects on the brain are documented, especially at Wisconsin. We have a big center that looks at that. And we also know that stress affects cognition. So this is another promising area of treatment. Now, what's really exciting is that some centers are working on combining all of the things that I just mentioned into one multimodal treatment strategy. And so one of those studies is called FINGER, and it's the Finnish Geriatric Intervention Study to Prevent Cognitive Impairment and Disability. And so it's a multi-component intervention. Instead of trying to figure out, okay, what is it about exercise? What is it about cognitive activity? It's combining all and just saying all of these things are probably going to be helpful. And that's the case. That's what we're seeing in aging people who went on this intervention schedule where they received nutrition counseling, exercise, cognitive training, and then also medical management of any other risk factors that have to do with brain health. And what they see over time is that these adults who are on the intervention tend to have a lower rate of cognitive decline over time and a lower risk of dementia. So that then prompted something called worldwide fingers. And so multiple countries are implementing a similar treatment, including the US. And the US study is called Pointer, US Pointer. And so you can look that up too as a potential study to participate in. It's called US Pointer study. So it's looking at the same factors. Another multi-domain intervention that's getting a lot of traction is dance classes. So if you think about it, dance is physical activity, social activity, and cognitive activity, because you have to learn these steps. And so this is another treatment that a lot of people are interested in, and it's been shown to really help people with Parkinson's disease. And so we're trying to see if it actually carries over into dementia of other types. Okay, so last thing is, what about people who are living with dementia now? What do we do to help people have a better quality of life? So one thing is physical activity, however possible. It's not always easy or possible for people who are living with dementia, but any type of physical activity tends to increase engagement, increase social ability, and also decrease some of the aggressive behaviors or difficult behaviors that we can see in people living with dementia. Occasionally people can get combative, angry, or depressed or withdrawn. And so physical activity can actually relieve some of that in some people. Social engagement, as I mentioned, cognitive engagement, however possible, and extremely important for the person living with dementia is that the spouse or care partner have respite. As you know, we can't care for someone else if we're not caring for ourselves. And so that caregiver burden can be really, really difficult for the person doing the caregiving, but also for the person who has dementia. So as a speech language pathologist, a lot of people don't know that speech therapists are actually trained to work with memory and other cognitive skills besides speech. And for many years, speech therapy wasn't covered by insurance for people with neurodegenerative disease. And the thinking was, they're going to decline, so we're not going to pay for treatment. That thinking has changed, and there's a lot that speech language pathologists or other therapists can do for people who are living with dementia to maximize their life participation. So one potential and extremely powerful tool is an external memory aid for someone who is having severe memory problems. So this is an example of a memory book or a memory wallet that sort of has these cues about what that person likes, what their name is in some cases, where they live, any kind of key information that can actually help another person have a conversation with them. And then we build all kinds of other skills by doing that. Other reminders, pill boxes, pill dispensers, all of these things that can help maintain independence as much as possible. There are group interventions that are being implemented and being studied, especially in nursing facilities, long-term care facilities, that involve a whole group of people, and they either work on cognitive stimulation in a group or this idea of Montessori intervention for people living with dementia is a beautiful and wonderful treatment strategy where there's a lot of sensory information and sensory materials available. And so a person living with dementia could actually, like you see in that picture there, they have these flowers and they put them into a vase and put them around the table. And something that simple has been shown to reduce those aggressive and difficult behaviors that we see in people with dementia. So really simple activities can really have a powerful effect. So there's also environmental modifications. So there are visual impairments that come with Alzheimer's disease or other dementias. And in some cases, we see a problem with eating because the contrast, let's say there's a white plate on a white tablecloth, the visual problems that come with dementia, there's not enough contrast there to call attention to the food, and the person just might not eat. But we've done studies to show that if we have a contrast like a white plate on a red tablecloth, just even that small modification can trigger the visual of the food and have them increase their eating. So there's a lot of modifications that we can make to the environment. This kind of name tag, for example, this green and white background was more visually preferable to people living with dementia, and they're able to see this and know that person's name versus this kind of cluttered and small name tag. So really simple, but can go a really long way. So another question that comes up is, how do you talk to a person living with dementia, especially if they're repetitively asking you questions, which is common. So when am I going home? When am I going home? And it's hard to know how to respond to that person when that's happening. And so there are strategies. Speech language pathologists have training to work with caregivers, nursing facilities, to kind of know how to communicate to the best way possible for a person with dementia. So one program is called FOCUSED, and it's an acronym. And it stands for, it helps the care partner sort of remember, okay, what do I need to do? So here they're sitting side by side, but it's more preferable for people with dementia if you look at them face to face. So that's the first part of the acronym, is get on that person's level and speak with them face to face. Orient, so you might just have to somehow say who you are each time you see that person. And that can go such a long way. And instead of quizzing them, who am I, just offering the information right away can reduce a lot of frustration and anxiety in people with dementia. Trying to keep a continuity of a conversation, so a back and forth as long as possible, and unsticking. So sometimes they might have trouble recalling words. And so you can ask them, do you need help thinking of that word? Can I help you think of that? So that's one strategy. So we want to structure our own language to be as simple as possible, because there's comprehension problems with people living with dementia. So keeping things short, keeping things at yes, no questions instead of what did you eat for breakfast? That's a really hard question. But if you say, did you have cereal or eggs for breakfast? That's a little bit easier, giving a choice. And then exchange. So this is that piece about not quizzing, which is so hard, especially if it's a spouse, because it's really hard to accept where that person is at. And you want to just, don't you remember we went to, don't you remember, that kind of thing. And it's really hard not to do that, especially in the beginning. And we have to give ourselves a lot of compassion about that. But it's not helpful for that person living with dementia. And so commenting or asking questions, but if it's problematic, then just redirecting to a different topic or looking at pictures together or something else like that. And then being as direct as possible. So keeping our language as short and direct as we can. So I think, here's our summary before we take your questions. There are many causes of cognitive decline and many causes of dementia. And some of the causes can be treated, such as depression or hearing loss or sleep apnea. And there are other types of dementia where the cause can't necessarily be treated, but knowing what type of dementia is extremely important for treatment. We know more than ever about risk factors, and there are many things that we can do to keep our brains healthy. And there are so many exciting discoveries about early detection that are really going to lead to better treatments in drugs and otherwise. So I want to thank you so much for being here. And Rebecca and I are going to join together, and we're really excited to take your questions.
Wow, this is Jeanette. I just wanted to say this is amazingly informative. And so we're going to get to some of the questions. Okay, since early detection seems very important in prevention, should we all get screened for amyloid plaque routinely at an early stage, or early age, I should say?
That's a great question. At this point, I don't think they're going to recommend screening for amyloid across the board, but I wouldn't be surprised if, as we have easier ways to screen for it and stronger data supporting it, that like the amyloid clearing things, I think maybe in 5 to 10 years, it will be more routine to get screened for amyloid.
I do think, to add to that, that if you feel like you notice a memory problem in yourself or in your spouse or friend, then that you should definitely get a screening for, because the earlier we can know if that is a problem, the earlier we can treat what we can treat, and the earlier we can plan for the future and just sort of understand what's going on. So in that sense, we highly recommend that you get screened for cognitive impairment if you're noticing anything.
Do we know how effective style changes are in prevention of forming plaques and tangles?
We don't know if those are effective about preventing the plaques and tangles. There really is no compelling evidence to say that if you start exercising now in midlife, that you're going to stop the plaques from occurring. Rena, do you want to say more about that?
Right, we're all trying to figure out. Let me back up a step. One of the analogies I use for the amyloid onset is that it's like stepping on an escalator, that everybody's milling about around the escalator, but we don't know who's going to step on. We do know that having an ApoE, E4, I saw a question pop up about that. That's a genetic mutation that increases risk of amyloid, but we don't know when. Some people with E4 alleles in our sample got amyloid in their 50s and some in their 70s. So we can't tell necessarily. And so far, we haven't found anything else that predicts onset. But what we are seeing, like one of the reasons I wanted to share the Libra results was because we are seeing that having a lower risk score on those modifiable risk factors, actually, even if it doesn't change your amyloid, it is related to better cognitive health. So we might as well do the things we know help our brains be healthier.
Yeah, and one more thing is that we know a lot of people go to autopsy and have lots of amyloid in their brain and never showed any signs of dementia. And so there are people who are resilient to the amyloid, and that is another thing we really have to understand. But it's more compelling evidence that you should do all of these health-related things to build any kind of reserve in your brain that you can.
Okay, this is kind of a two-parter. Does everybody suffer memory loss as they age, or do some keep their memory intact? And you kind of mentioned that, but then the other thing is, do brain supplements help? Oh God, here's the names, like acetylcholine, alpha lipoic acid, and L-carnitine.
Well done.
God.
You, I don't know
So,
much about the
Are they
supplements.
helpful?
yes, very helpful. So the first one was acetylcholine, and that one is, the drug form that I mentioned earlier, Aricept, is a prescription drug of that. Regarding supplements of that, I don't know anything about whether or not the supplement, there's not a lot of data, I'm sure, to support any of the supplements yet. But people are looking into those, as well as fish oil and other supplements like turmeric. So all of these things are being investigated. It's just that the data isn't very compelling yet for those. And what was the other part? Oh, yes. And most people most people have a decline in memory, but more of that in normal aging is about a slowness rather than a complete loss. And so we just get slower in general as we age with many skills, but memory is one of them. So sometimes you have trouble recalling words as you get older, and then later the word comes back to you. And so that's kind of a slowness of retrieval. But in dementia, those words don't tend to come back to people later. So word finding problems are completely part of normal aging, but usually they don't disrupt your activities of daily living, or they come back to you later.
Well, that's great news.
Yes.
Another question. Ashby Village has a commitment to diversity, equity, and inclusion. Are there differences in brain functions related to diverse populations? What proportion of study participants are diverse, especially racially and financially?
I'm watching all of the questions come in, and they're incredibly wonderful questions. And this is really, really important. In general, Alzheimer's research has lacked sufficient diversity, particularly racial and socioeconomic. And there is a whole field now called recruitment and retention science, where people are trying to understand and do a better job. How can we do better? In Wisconsin, in about 2007, there was a decision made that we needed to do better. Were you on the team then? You were on the team. I was before I was on the team. And we added a Milwaukee office. We added people on our team with expertise in community-based recruitment. So we have in our sample about 15% that are racially and ethnically diverse. We have less socioeconomic diversity in Wisconsin, but part of that is Wisconsin. But we're constantly trying to improve on that, and it absolutely is necessary in research. But one of the things is researchers have to do it better. They have to engage with people in a way that's a reciprocal and synergistic relationship, instead of just saying, come in and let us study you. So.
There was a question, why is dementia and AD more prevalent among women? Or is it?
Good question, is it? So that's a really important question, whether or not it is. One factor is that women tend to live longer, and so they tend to get to the point of diagnosis more than men. But what else do we know about these differences?
I don't know off the top of my head other things, although some people think hormonal changes can play a role in brain health, and that women's hormones may change more, but that's a study like ours is actually going to help us follow this because we're watching, we have a lot of women in our sample who were premenopausal when they joined and as they're in. And I see somebody added a question about that I'll just address right now with estrogen and dementia. We have a colleague, well, a few years ago, I had the opportunity to see a panel of experts speak to this. And the thing that makes the estrogen question so complicated is it absolutely depends on where you are in the menopausal process, on whether or not estrogen is helpful or not helpful for cognition. So that's a really complicated question, but I would say, I think if I'm remembering right, if you're more than 10 years postmenopausal, estrogen is not something you want to do in terms of brain health.
One of the things that's come up, and we wanted to ask you, are you okay with sharing your slides?
Sure.
Okay, and I think Sue Yin might be able to help us know how that would be available. Sue Yin?
I can, once I get those, I will put those in the video recording description, and we'll also be sharing this presentation in our November newsletter. So we can also link to it there.
And you know, if you want to capture the questions that are coming in, we can take a stab at answering. I'm seeing some themes as they come through, and we might be able to throw in a few answers for things we haven't gotten that we might not get to in the time.
There was a question about how much does loneliness and living alone without a partner, kids, spouse, pets increase the risk for dementia and AD?
Yeah, for AD, I don't think we know enough about that, but for sure, there's a correlation anyway to lack of social engagement and risk of later dementia. So there's definitely a correlation. We don't know, what's causing what, but we see in these observational longitudinal studies anyway, that people who live alone, not necessarily unmarried, but people who are lacking in social networks tend to have an increased risk of dementia. And so that's why that social activity piece is so important.
Okay, and I think that there was a question that was really kind of important. There is so much fear about dementia. I feel like that adds to the stress, that adds to the chances of getting it.
Yeah, it's a really right. And so it's a deep and philosophical question too. The thing, so maybe spending time with what scares us about it and what we can do will decrease that. But with the advent of PET scans where you can see amyloid, there is more. We didn't talk at all about amyloid disclosure studies that are going on now, but there's interest in understanding what impact does knowing if you have amyloid in your brain have on your cognition. And we haven't sorted it all out yet. It's a really complicated question, but there are some studies that suggest that just knowing amyloid, people score lower the next time they take the tests because they've been primed to expect they're doing worse. So what I would say to any of you, if you do find out you have amyloid in your brain, instead of expecting that things will just go downhill for sure, remember what Kim was talking about, that there are lots of people who have autopsies and they find amyloid plaques and there was no sign of cognitive decline in life. And that many, many people can function very, very well when it's there.
Yeah, and I think I saw a question that's related to that about getting genetic testing. And it's very similar in that, especially that one APOE gene, that's a risk factor gene. So you could have that gene and you could go on to never develop any cognitive impairment throughout your life. And so then that becomes a question of, is that worth knowing for you? And I think maybe that this is an individual kind of basis where some people just want to know and it propels them to do more and more to reduce risk, where other people might just have a lot of anxiety and lower quality of life about knowing that kind of information that might not ever turn into anything.
I think at this point, I need to, as much as the questions have kept coming in, we'll stop it there. And I just wanted to say that our next Healthier Aging presentation is going to be on November the 18th from 1 to 2. And it's going to be on the care and exercise of your feet. Yes, I said feet, because sometimes we underrate this most important part of our body. Mary DeElia from Albany Y, with whom we hope to have future collaboration, is going to be the presenter for that one. So to the audience, if you've enjoyed this presentation, we hope that you will consider a tax-deductible contribution to Ashby Village. You can do so now by using the link in the chat box or on our website. And we want to thank you so much for joining us today. And thank you, Rebecca and Kimberly. That was absolutely fantastic.
Thanks for having us.
Thanks, everyone. Even though we can't see you all, we really enjoyed being with you.
Yep.